starts with decubitus. What is decubitus? We usually call it a decubitus of choice. Decubitus of choice means the patient does not have any uncomfortable at any particular position. Patient do not have any choice of position. Patient, if you ask the question, patient do not say I am comfortable on lying down, or I am comfortable on propped up, I am comfortable on standing. He doesn't have any choice. He feels not uncomfortable at any position. That is a decubitus of choice. But this question asking about decubitus is very important, because in case of gastroenterology, if we come to the gastroenterology part, then at a huge ascites, and the huge ascites can pull the diaphragm to the up. The propped up is which we mean that patient feels comfortable at 45-degree inclination. That is orthopnea. That is not the term propped up used in this gastroenterology, but you can say that patient feels comfortable in upright position, because a huge ascites can push the diaphragm up. So he wants to keep the diaphragm down so that he can inflate his lung properly. That maybe is decubitus. That is the decubitus. He feel comfortable. But you know what is orthopnea? Do you know what is orthopnea? Yes, no, no. Patient feels comfortable at in 45-degree position or upright position. Then lying down. It is a ominous sign of cardiovascular disease. It is ominous sign of cardiovascular disease. Sometimes in examinations, you are asked a patient why you are examining the cardiovascular first. Suppose the patient complained of respiratory distress, cough, and cough and respiratory distress and pleural edema. All these things can occur in cardiovascular system and respiratory system also. But you will have to make your choice of examining a system first. That is your choice. Examiner not in a long case. The examiner, you are not told this system. You are not told in a long case. It is your choice which system you will examine first. So sometimes examiner first question comes from the examiner. The patient has respiratory distress and cough and fever. So why you have examined the respiratory system first, not the cardiovascular? That may be the first bouncer ball you can face. So all the symptoms you are telling can occur both in respiratory and cardiovascular. Why you have choose to examine the cardiovascular system first or the respiratory system first? You have to give the answer. Just why I am giving. So the reason I am telling this is that if there is orthopnea, it is an ominous sign for cardiovascular disease. Usually do not occur in respiratory disease. In asthma patient or a COPD patient, do not feel comfortable on upright or propped up. No, there is a particular choice of this. Patient may feel, but orthopnea particularly if there is PND. You know what is PND? Paroxysmal nocturnal dyspnea. You know what is PND? Paroxysmal. The name suggests there is a paroxysmal nocturnal, usually occurs in the night, and dyspnea. Patient usually goes to sleep, and after having a sleep 1 or 2 hours, he feels respiratory distress. He then sit up in the bed and hang his leg on the side of the bed, and keep in that position sometimes, and the patient relieved automatically. That is a PND. Why the PND occurs? Usually PND, the exact cause is not known, but usually most causes that the patient has huge edema. When he lies down, some edema fluid comes to the system, and the heart cannot cope up with that extra volume, and it becomes there is increased respiratory distress at midnight. That is the most probable reason for having midnight dyspnea. That is called PND. Thus, PND is very much suggestive of cardiovascular disease. It do not occur in respiratory disease. But if there is a chronic cough, seasonal cough, patient telling that he is suffering from cough for 3 months in a year for consecutive years, and the cough is very much productive, Then it is a symptom of the respiratory system. Usually seasonal chronic cough. It is a chronic bronchitis. Chronic bronchitis is a definition of patient suffers from 3 months in a year for consecutive months, for consecutive years. So this history suggests that so when you are asked why you have examined the cardiovascular, not the respiratory, prepare for the question. Prepare for the question why I am examining the respiratory first, not cardiovascular. You may face these questions. Prepare for that. Anyway, so this is about respiratory disease. The PND, orthopnea, these are very much suggestive of cardiovascular disease, and this ascites with sometimes edema. Ascites patient, GI patient, ascitic patient, or the hypertensive failure may have edema. We come to the edema later, but in a cardiovascular case, edema occurs first. But remember it, in a cardiovascular case, edema occurs first, ascites much late. But in a GI system, liver disease, ascites occurs first and edema late. So this history is very important. Patients, which occurs first? Your swelling of abdomen or your swelling of feet? That question is very important. Now come to consciousness. After decubitus, we will have to ask about the consciousness. We will usually rate that patient is conscious and cooperative and oriented to time and space. That is a dictum we tell like this. But what are the unconsciousness level of there is consciousness, unconsciousness in a GI patient. Our discussion is on GI patient. That's why you are focusing on GI system. So hepatic coma, you know what is hepatic coma? It is hepatocellular hepatic encephalopathy and hepatic failure. There is building up of ammonia in the blood. That ammonia causes some disturbances in neurological function, higher function, that causes hepatic coma. And this now the hepatic coma is and hepatic coma may be increased by mixing of portal and systemic blood. That have that conceptions, because after that you will feel this face these questions. Why this ammonia? There is building up of ammonia in the blood. If there is portosystemic anastomosis, portal vein mixes with the systemic vein. The portal vein definitely causes more ammonia than systemic vein, because the ammonia is absorbed from the colon. So portal vein contains more ammonia than systemic vein at any point of time. So if there is a mixing, more will be the chance of hepatic failure, hepatocellular failure, or this hepatic coma. So portosystemic anastomosis, it aggravates hepatic coma. Anastomosis, if there is portal hypertension and portal hypertension mixes with the systemic blood, there is the chance of hepatic coma. Then the hepatic coma, usually you are not asked about the questions, but just for remembering, and you can face this question. You can learn more. If you learn more, you will see that hepatic coma is a sign of decompensation. Sometimes we call it as a decompensated liver disease. We call it liver disease. You have found a liver disease. You call it. Then the question you will ask: is it compensated or decompensated? What are the signs of decompensation? This jaundice is a sign of decompensation. Remember this. Examiner will ask you. If you are telling it is a decompensated liver disease, what is the signs of decompensation? Usually, jaundice is a sign of decompensation. Ascites is a sign of decompensation. And this hepatocellular failure and hepatic coma is a sign of decompensation. These are the signs of decompensation you will have to tell. There is not a compensated liver disease, there is a decompensated liver disease. DCLD, we often call it DCLD, decompensated liver disease, DCLD. Sometimes you will see some big doctors, they do not have the time to write the whole thing, they write it DCLD. This is a decompensated liver disease, DCLD. So, hepatic coma, more you will learn. When you will learn more, you will see that we classify this liver disease, chronic liver disease, in a child classifications. Child classification is for prognostic important. Child A, child B, child C. If you are interested, you can learn in your home. I am not telling the details of it. The child A, child B, child C. You should know that this hepatic failure or hepatic coma is a child C. Child C has a very bad prognosis. Their 1 year survival is very low. So it is child C. It is not child. It is actually child pug. Child, CHILD, child hyphen pug, PUGH. Pug classification, child ABC, but for our convenience we call it child A, child B, child C. When there is liver disease, chronic liver disease, in the undergraduate you may not have to face these questions, but in postgraduate definitely examiner will ask which class it is, child A, child B, child C. You will have to know what is child ABC. There are 5 parameters, three numbers in each parameter, 3 into 5, 15 is the highest score, child code. And this 10 to 15, 10 to 15, 10 to 15 is a child C. So you know you can, if you are interested, you can study this in your home. It's not so hepatic coma is in the child C. It is in the child C. Coma, when it is coma, it is always child C. Then renal cause, renal is a terminal stage of uremia that can cause unconsciousness or impaired consciousness. Then poisoning, barbiturate poisoning and morphine. Any question? তোমরা নিজেরা কথা বলো না, যদি না বলো আমাকে আমার সাথে কথা বলো, যে কি হয়েছে, কি বুঝতে অসুবিধা হচ্ছে, না বুঝতে বলো কি আছে, আমরা ক্যান রিপিট, ইটস এ স্মল গ্রুপ ক্লাস, নো প্রবলেম। ইফ ইউ হ্যাভ এনি কোশ্চেন্স ইউ ক্যান ইন্টারাপ্ট মি এট এনি পয়েন্ট অফ টাইম। আমরা সেই কথা সেখান থেকে ওই জায়গায় ডিসকাস করতে পারি, নো ম্যাটার, করা যেতে পারে, অসুবিধা নেই। তো পয়জনিং, barbiturate and morphine poisoning, and head injury, subdural hematoma. Subdural hematoma, it is a surgical condition, but I have kept it this cause in the medicine because sometimes the patient, suppose in your emergency room you are there and the patient come with jaundice and unconsciousness. Patient has come with unconsciousness, patient is unconscious, and you have found the patient is jaundice. There is moderate to deep jaundice. What may be the causes? Usually we consider there are many causes, but usually consider 4 causes. The emergency patient come in the emergency room at unconscious state, only positive finding is jaundice. Yes, but a fever wouldn't. If I tell it is a fever, then falciparum malaria, leptospira will come first. But I have don't the patient is not fever, no, don't have not, is a febrile patient. In unconscious state comes with the jaundice. If you get a smell of alcohol, then it is all right. This alcoholic patient can got unconscious and alcoholic hepatitis had jaundice. Most likely the patient is alcoholic and have jaundice and unconsciousness. What is the cause of jaundice? Unconscious jaundice. Then this is an acute alcoholic intoxications. Patients jaundice. Wernicke's encephalopathy. You know what is Wernicke's encephalopathy? Wernicke's, WERNICK. Wernicke's encephalopathy. Wernicke's, yes. This is encephalopathy. Occurs in alcoholic patients. Vitamin B1 deficiency, thiamine deficiency. Wernicke's encephalopathy. Or patient may have hepatocellular failure, coma, hepatic coma. Patient had a jaundice and patient has come and now he is comatose because of hepatic coma. So this jaundice with hepatic coma may be hepatic coma. Maybe Wernicke's encephalopathy, WERNICK. Wernicke's encephalopathy in alcoholic patient. Patient is alcoholic, or it may be patient. Suppose sometimes it happens that patient is sometimes alcoholic patients, they fall in after under the influence of alcohol, there is a fall, and fall can cause subdural hematoma, and because of alcohol ingestion patient has jaundice. So in that cases subdural hematoma comes into the differential diagnosis of this the acute alcoholic intoxication or alcohol withdrawal. With alcohol withdrawal usually have patient is very much agitated, but as acute alcoholic intoxications, sometimes patients may be hypoglycemic also. Sometimes there is a hypoglycemia is one of the causes of hypoglycemia. Acute alcoholic intoxications. Patient may come with unconscious with jaundice. Because patient is alcoholic, patient may have jaundice. Patient may come with maybe Jaundice encephalopathy. It may be hepatic coma. It may be subdural hematoma. These are the 4 diagnoses. Subdural hematoma as a medicine doctors we do not consider it, but it is a common finding. The patient is alcoholic, having jaundice. It had a history of আসছিল হঠাৎ নর্দমে পা পড়ে গেল, পড়ে মাথায় লেগে গেল, মাথার পেছনে লেগে গেছে, leg is subdural hematoma. মাথা পেছনে মানে স্ক্যাল্পে তো হেমাটোমা না, it is a inside subdural hematoma. That subdural hematoma cause the patient unconscious. এবার তুমি মেডিসিনে পেশেন্ট জন্ডিস দেখে অনেক কিছু ভাবছো, হেপাটাইটিস ফেলিওর হবে, কিন্তু পেশেন্ট অ্যাকচুয়ালি তুমি হিস্ট্রি নিয়ে জানলে যে পেশেন্ট নর্দমায় পায়ে পড়ে গেছিলো, পড়ে গিয়ে আন্ডার দ্য ইনফ্লুয়েন্স অফ অ্যালকোহল মাথার পেছনে আঘাত পেয়েছিল, এখন সাবডুরাল হেমাটোমা। আর জন্ডিসটা তো অ্যালকোহলিক কারণে আছে, এমনি আছে। So these are the 4 main causes. That's why I'm telling they kept this head injury or the defunctionary. Now then we discuss about build. Now then we discuss about build. Build, short build, by definition, it is a below 3rd percentile of a normal population of the same age as sex. Definition short build. Tall build, there is height is above 97th percentile of the normal populations. Short, what are the causes of short build? It will be nutritional, kwashiorkor, marasmus, rickets, tuberculosis in the childhood, that cause give birth and shortening of spine. Patient may have lose height, adult height, short height. Then gluten enteropathy. Again, there is protein losing enteropathy. Protein loses protein, like and suffering from short height. Apart from this, the chronic renal disease, Alport syndrome, chronic renal disease, from childhood, worm infestations, and glycogen storage disease. These diseases can cause short height. Adult height may be short. The patient is tall. What is the cause of tall patients? Marfan syndrome. You know Marfan syndrome, arm stretching of arms. They are very much arm to arm, finger to finger distance is more than this head to foot distance. Usually head to foot distance is equal to your stretched arm distance, but arm distance will be more in Marfan syndrome because they have longer limbs. Marfan syndrome and Klinefelter syndrome, 46 disease, there is a 46 XXY Klinefelter syndrome that also causes tall, patient may be tall. I have kept Marfan and Klinefelter is a common chromosomal disease, and you can if you have the patient in the ward, they can give you one patient like this, and there is a tall, quite. So then we check about nutrition. After that, we check about nutrition. But how the nutrition is checked clinically? It is a mid-arm circumference from the acromion to the elbow joint, choice of middle of the arm, and measure the circumference of the middle of the arm. That we measure for nutrition of the patients. It is a mid-arm circumference. Subnutrition, body weight less than 10% of that of the average relation to the age and sex. When you called obesity is 20%, excess overweight, but of the ideal weight. But obesity nowadays is defined in terms of BMI, body mass index. If the body mass index is more than 30, we call it obese, and 25 to 29.9, we call it overweight. And this obesity is also, there is one waist hip ratio also. Apart from this BMI, there is one waist hip ratio to define obesity. Anyway, if you are interested, you can go in your home and read it. Causes of obesity, there is hyperthyroidism. You know that myxedema patients are flabby, they are overweight. Cushing syndrome. The Cushing syndrome, there is accumulation of fluid in the body and the patient looks flabby. Then hypothalamic disorder. Then hypothalamus, you know that hypothalamus is a higher center for satiety center. If there is hypothalamic tumor, patient may eat more because patient do not feel satiety. After taking food, don't feel that I have taken food, don't feel satiety. So in hypothalamic tumor, the patient will be obese because of the dysfunctional satiety center. Then comes your pineal loma, insulinoma. Again, the insulin is a growth factor. Insulin is a growth factor in the body that causes increased muscle mass and increased fat. So insulinoma. And there is preterbiliary Prader-Willi syndrome and Lawrence LMB is Lawrence-Moon-Biddle. Lawrence-Moon-Biddle, you have probably written, you have read these things. Prader-Willi and Lawrence-Moon-Biddle syndrome. These are the syndromes causing obesity or overweight. But the important cause has not been mentioned here is the metabolic syndrome. You know, nowadays metabolic syndrome is the most common cause of obesity. Metabolic syndrome, and the crux of the defect in the metabolic syndrome is insulin resistance. The metabolic syndrome, why the metabolic syndrome occurs, where the pathology is, it is number one, it's a single term, it is insulin resistance. The insulin secretes normally from the islet cell, alpha cell, you know that insulin normally is, alpha cell is normal, secretes insulin normally, but it in the periphery it cannot act. That is called insulin resistance. That is, insulin resistance is the most common cause of obesity nowadays. Anyway, now comes to the phases. That has not been written, but you should mention metabolic syndrome. The obesity is a part of metabolic syndrome. No? Metabolic syndrome has other features also, but one of the important feature is obesity. Phases. Now, in relation to gastroenterology, you should know that what is hepatic phases. A cirrhosis of liver, if you examine carefully, if you watch carefully, you will see that patient has hepatic phases. These features, there is sunken eyes, there is hollow temporal fossa, and pinched up nose. These are the features of and muddy complexion, and parched lips, muddy complexions, and icteric tinge. These are the features of hepatic phases. In cirrhosis of liver or in also chronic liver disease, we get hepatic phases. These are the features of hepatic phases. Now there is another phases is called moon phases. This is a this is almost a circle like phase. It occurs in Cushing syndrome and occurs in steroid therapy, and there is glomerulonephritis and mixed edema. You know what is Cushing syndrome? It is excessive steroid in the body. It is a cortisol. Excessive cortisol in the body. Cushing syndrome. What is Cushing's disease? Cushing's disease. Anybody know? Yes. It is due to pituitary adenoma causing more ACTH. That is also cause hyperadrenalism or hypercortisolism, hypercortisol secretion. That if it is due to serious secretion from the pituitary, then it is called Cushing's disease, or the excessive production of cortisol in the adrenal level, then we call it a Cushing's syndrome. Same disease is called Cushing's disease or Cushing's syndrome. And ACTH production may be ectopic also. Ectopic means ACTH may be produced by ectopic ACTH syndrome. Yes, carcinoma, lung carcinoma. Yes, lung carcinoma. It is a part of the paraneoplastic syndrome. What is called the paraneoplastic syndrome. This is a part of the paraneoplastic syndrome. The lung carcinoma can secrete ACTH. Then we call it a ectopic ACTH syndrome. The features will be like that of Cushing syndrome, because there is ACTH is produced by the carcinoma cells. Anyway, so say this is the pituitary adenoma, ectopic ACTH syndrome, or it is excessive steroid from the adrenal gland, or iatrogenic. You can give steroid for a prolonged time. A patient may have Cushing's syndrome. Patients taking, often we see in the ward, the patient is taking steroid for a long time for any reason, for collagen vascular disease or from asthma, like that. Taking steroid for a long time can have Cushing syndrome. And patient also has buffalo hump. Now, Cushing syndrome patient has moon phases and a buffalo on the neck. They call it the buffalo hump. There is a hump in the back. It's called buffalo hump. Cushing's patients. So this is moon phases. And elfin phases is another phases occurs in the supravalvular aortic stenosis. This is called Williams syndrome and may be associated with hypercalcemia. This Williams syndrome may be associated with hypercalcemia, and they have supravalvular aortic stenosis. Now we will look for anemia. You know what the sites for anemia you look for? The lower palpebral conjunctiva, It is not. It is a tip and dorsal of the tongue. There is a printing error. Tip and dorsal of the tongue, the soft palate, nail beds, general skin, palm and soles. If you are asked where the anemia is seen, don't stop after telling that it is only lower palpebral congenital. No, all the things to be mentioned. So lower palpebral congenital, tips on dorsal tongue, soft palate, nail bed, general skin, and palm and soles. This is all of the places to be looked for patient having anemia or not, or pallor. We call it, so better to call it pallor. Pallor is we see an anemia is actually, if you consider it strictly, anemia is a lab finding. When you get a hemoglobin less, we call it anemia. But what you see is a pallor, not anemia. Anemia is a lab finding, like jaundice. Icterus is a yellow discoloration you see is called icterus. Jaundice is the lab finding, high bilirubin. It is a lab finding. But we often use the term intermixingly. We don't much strict about that, but to be very strict, to be very meticulous, you should take it is icterus, not jaundice. It is pallor, not anemia. But anyway, so anemia. So they also call it anemia. Causes, what are the causes? There are several causes of anemia, but try to remember these causes. This is nutritional deficiency after gastrectomy. After gastrectomy, there is nutritional problem, pernicious. There is a intrinsic factor goes out. So after a gastrectomy, there is anemia, and malabsorption syndrome. I have stressed on this gastroenterology causes of anemia. What are the causes of gastrointestinal? Their anemia may have several causes, but what are the gastrointestinal cause? There is poor nutrition, or maybe this your after gastrectomy, malabsorption syndrome, and chronic liver disease can cause anemia, bleeding from peptic ulcer, bleeding hemorrhoids, and portal hypertension. Portal hypertension, portal hypertension, there is portal varix and there is bleeding. Hookworm infestation and Typhimurium latum, T-latum, Typhimurium latum infestation. This scurvy, pernicious anemia. Pernicious, you know, there is a loss of intrinsic factor. Drugs like methotrexate, ferritin, that can cause anemia. Several drugs, many anti-cancer drugs cause bone marrow suppression and anemia, drug induced. And hemoglobinopathies, hemoglobinopathies, thalassemia, hemoglobinopathies, sickle cell anemia. These are hemoglobinopathies that patient has anemia. And GCPD deficiency, CKD patients. CKD patient, there is a erythropoietin deficiency. Erythropoietin is secreted from the juxtaglomerular cell of the kidney, and if there is no erythropoietin, there will be anemia. So CKD patient may have anemia. CKD patient has many reasons for anemia. One of the reason is lack of erythropoietin. IBD, inflammatory bowel disease. Inflammatory bowel, Crohn's and ulcerative colitis, Crohn's disease and ulcerative colitis, two diseases conjointly called as inflammatory bowel disease, IBD. There is and if this is called anemia of chronic infections. If there is a chronic disease, any chronic disease can cause anemia, then we call it as anemia of chronic infections. Then it's come to cyanosis. The reduced hemoglobin in the blood more than 5 gram. If the amount of reduced hemoglobin in the blood more than 5 gram for 100 cc, then blood becomes bluish. That is called cyanosis. বলো কিছু বলবে? কিছু বলছো? না থেকে আছো। Cyanosis. Oxygen saturation is usually less than 85%. If there is cyanosis, oxygen saturation in room air will be less than 85%. All the causes of cyanosis, there are several causes of cyanosis. I have given stress on gastroenterology causes only. Gastrointestinal causes, there is methemoglobinemia, aniline and nitrobenzene poisoning. There is ingestion of aniline or nitrobenzene that cause methemoglobinemia. And also there is hemoglobin is converted ferric form is hemoglobin is converted to ferric form. That's what is hemoglobin. There is the ingestion of aniline and jaundice. Again, it is better you call it icterus. You can call it jaundice, no problem. There are several types of jaundice. Obstructive jaundice, mainly we divide it into obstructive jaundice, hemolytic jaundice, and hepatocellular jaundice. Obstructive jaundice is mostly the surgeon's part, but we can also have obstructive jaundice as a medicine student. You can have obstructive jaundice, but any obstructive jaundice, the features is itching. Itching is a feature of obstructive jaundice, skin itching and bradycardia. The pass rate is low. Bradycardia is a feature of obstructive jaundice, and the clay colored stool. You know the obstructive jaundice, the stool is clay colored, but hemolytic anemia, the stool is high colored, not clay colored. High serum alkaline phosphatase and low high serum alkaline phosphatase, the features of obstructive jaundice, and there is low vitamin K. The hemorrhagic low due to low vitamin K, there is hemorrhagic manifestations. What are the causes of this obstructive jaundice? On medicine point of view, we should consider CA liver, carcinoma of liver. There is lymphoma, Hodgkin's disease. Why there is jaundice in Hodgkin's disease or lymphoma? Because there is, due to lymph node enlargement, there is obstruction of the porta hepatis. Around the porta hepatis, there is lymph node around the porta hepatis. It obstructs the porta hepatis. So it is obstructive jaundice. But it is a medicine cause. Lymphoma is a medicine cause. Hodgkin's disease is a non-Hodgkin or Hodgkin lymphoma is a medicine cause. But that can present as a obstructive jaundice due to lymph node in the porta hepatis. Now, this is the CA head of the pancreas. Often we see in the medicine ward, we see that is the CA head of the pancreas. The gallstone, admitted in the medicine ward, sometimes gallstone, CA gallbladder. Pregnancy can cause some jaundice. Pregnancy can cause jaundice. That jaundice may be obstructive features. Drugs like carbamazepine and oral contraceptive pill. These medicines also can cause obstructive jaundice. Now, hemolytic jaundice. You know, there is hemolytic jaundice is due to excessive hemolysis of the breaking of our red blood cells are broken disproportionately. That's why there is hemolytic jaundice. It is featured as the red cells are destroying, so features are anemia. Hemolytic jaundice should be associated with anemia. Usually associated with splenomegaly, because spleen has to remove all these degraded particles, so it functions more, and there is splenomegaly. And there is reticulocytosis. Very important features of hemolytic anemia. Increased reticulocyte count because of rapid production of blood cells from the bone marrow. The immature cells comes into the system, which usually do not. Because of rapid turnover, immature blood cell RBCs come to the system. It is called reticulocyte. More nucleated RBCs. Reticulocyte count rise. And there is stercobilin in the stool. These are the features of hemolytic anemia. This is anemia, splenomegaly, reticulocyte count high, and stercobilin in the stool. Now this comes hepatocellular jaundice. What are the causes of the hepatocellular jaundice? You know the causes are viral hepatitis. Viral hepatitis A from anywhere. Hepatitis A is usually long standing, but any chronic hepatitis like hepatitis B or hepatitis C can cause anemia. Viral hepatitis and hepatitis is or hepatitis. Sorry, we are discussing about jaundice. So any hepatitis can cause jaundice. A, B, C, D, E. Any hepatitis can cause jaundice. It's viral hepatitis. Other than this hepatitis A, B, C, D virus, very important, Epstein-Barr virus and cytomegalovirus also can cause hepatitis, acute hepatitis. Then other than virals, you know that malaria can cause jaundice. Malaria jaundice is not due to hepatocellular; it is actually broken. RBCs are broken down. That's why malaria has caused jaundice. Leptospira is the Leptospira ectodermologica, leptospira disease. Fatty liver disease. Fatty liver disease is nowadays the most common cause of jaundice. Fatty liver disease is a part of the metabolic syndrome. We are discussing about metabolic syndrome, the insulin resistance. The starts with insulin resistance, and patients have metabolic syndrome. And fatty liver is a features of metabolic syndrome, and probably is the number one cause of liver disease nowadays in the world. Probably drugs like ATD and paracetamol. You know, drugs, antitubercular drugs can cause jaundice. In any patient you start antitubercular drugs, you must look for jaundice at least after 1 month. better if you look it after 3 weeks, whether there is any jaundice, because all drugs, INH, rifampicin, pyrazinamide, all can cause jaundice. So, except ethambutol. Ethambutol usually do not cause jaundice. But INH, rifampicin, pyrazinamide, all three drugs can cause jaundice. Most notorious is pyrazinamide. Then rifampicin. Then if you chronological which drugs causes which entity is causing most jaundice is pyrazinamide. Because after jaundice, if you want to start, this pyrazinamide is most commonly cause jaundice. After pyrazinamide, rifampicin, and after rifampicin is INH. So all three drugs can cause jaundice. Other than paracetamol, paracetamol poisoning, acetaminophen or paracetamol poisoning, excessive paracetamol can cause jaundice. And poisoning, very important, copper sulfate poisoning. Tute high copper sulfate, copper sulfate poisoning can cause hepatitis and jaundice. Yellow phosphorus and alcohol, of course, alcohol is there. So, all these can cause hepatitis or jaundice. And hepatitis or jaundice is physiological in newborn. Newborn patient it is physiologically present. And Gilbert syndrome. There are 3 syndromes that you discuss in your hepatic region. One is Gilbert, Crigler-Najjar, and Dubin-Johnson. 3 syndromes you will have to know relating to liver. One is Gilbert syndrome. Gilbert is the uptake defect. Liver cannot uptake the bilirubin. That's why there is jaundice. So it is a hemolytic jaundice. Almost it is it is a unconjugated bilirubinemia. Unconjugated hyperbilirubinemia. Gilbert, because liver cannot take the excess bilirubin from the blood. So there is unconjugated hyperbilirubinemia, because conjugate could not occur in the liver. That's why it is unconjugated hyperbilirubinemia. It is Gilbert syndrome. Crigler-Najjar is a mixed, partly conjugated, partly unconjugated. Dubin-Johnson is a purely obstructive, because Dubin-Johnson always conjugated hyperbilirubinemia. So Gilbert is a hemolytic, and like hemolytic jaundice, Gilbert syndrome. Anyway, then comes to pigmentations. In our last class, we also discussed about some about pigmentations. Now, usual sites we see for pigmentation, you look for what sites, like your inside your cheeks, crease of the palm, and pressure points. Pigmentation may be physiological in racial variations. Some parts we are pigmented peoples. Foreigners are not less pigmented. There are some racial variation in pigmentations, right? And there is pregnancy. Pregnancy causes hyperpigmentations. All this causes hyperpigmentation. Von Recklinghausen's disease. Von Recklinghausen's disease is neurofibromatosis, multiple neurofibroma. That causes von Recklinghausen's disease, and tuberous sclerosis. These 2 diseases causes pigmented spot called café-au-lait spot. Café-au-lait spot you have seen. You just go and check it from Google, or you download these café-au-lait spots and see the picture. If you can see in the patient, you will not forget it for your life. There is a hypopigmented area in the back, and margins are irregular. These are typical features in the back. Hypopigmented area, margins are black. It is some larger area. Café-au-lait spots. If you have not seen it, you can download a picture from Google. You can do it from Google or anything. Download a picture and see how the café-au-lait spot looks like. It occurs in von Recklinghausen's disease or neurofibromatosis and tuberous sclerosis also. Peutz-Jeghers syndrome, we have discussed it in our previous class. The Peutz-Jeghers syndrome, there is multiple polyposis coli, and there is pigmentation in the cheek. Hyperpigmentation, acanthosis nigricans. Acanthosis nigricans is a sign of insulin resistance. Acanthosis nigricans, usually there is a hyperkeratosis in the nape of the neck, and at the back of the neck there is a deep hyperkeratosis, black, and there is a papilla formations, and black, very much black. This is called acanthosis nigricans. You can see it in many patients, because insulin resistance is nowadays a very common feature. You can see it in your ward. If you roam about, you will see 2-3 patients with acanthosis nigricans, deep black and raised up spots from the. This acanthosis nigricans is the features of insulin resistance. This is a very important question because because of the fact that it is very common. If your patient have acanthosis nigricans, then examiners definitely will draw your attention to it. What is this in the neck? There is hyperkeratosis, black hyperkeratosis. So what is this? You will have to tell it. This is acanthosis nigricans, and also found in axilla. Also found, look for axilla also. Acanthosis nigricans. Then definitely they will face the questions why it occurs. One line answer is, sir, is the features of insulin resistance and metabolic syndrome. Anyway, then comes your exposure to radiations. Yes, any part exposure to radiation can cause hyperkeratosis and hyperpigmentations and hemochromatosis, porphyrias, you know, due to why the porphyria occurs, you know, after hemoglobin, after the heme part, the rest part is globin, and the porphyria is due to the disorder of the globin part. The globin part, the excretion of the globin part, the defect in the excretion of the globin part, that is called porphyria. This is porphyria cutanea tarda that causes hyperpigmentation. Anyway, then and exposure to Kala-jar and pellagra. These two diseases can cause hyperpigmentation. Kala-jars and pellagra, hemochromatosis and porphyria cutanea tarda. These are the causes of medicinal causes. Medicine causes of hyperpigmentation. Drugs like busulfan and busulfan can cause hyperpigmentation. Fixed drug rash can occurs due to any exposure to any drug, but sulfonylurea is most common. That causes fixed drug rash. Usually remains for a very long time. There is a black and area in the skin, remains for a very long time. Usually there is a history of exposure to sulfur drugs. And patient may have hypopigmentation also. There is a less pigmentation. Causes are vitiligo and albinism. Then leprosy can cause hypopigmented spots, tinea versicolor psoriasis, and hypopituitarism. All these diseases can cause hypopigmentations or white looking skin, hypopigmentations. Leprosy, leprosy can cause hypopigmentations, right? Leprosy, you know how many types of leprosy are there? Two types. What are the types? Paucibacillary, multibacillary. Multibacillary is leptometas, also called lepromatous leprosy. Paucibacillary also called tubercular leprosy. There are other varieties also. Intermediate varieties also there, BT, BB, BL, there are varieties. But tuberculoid has a high immunity. Patient has immunity is very high. That's why it is tuberculoid. And the lepromatous leprosy, the immunity is less. That's why it is lepromatous leprosy. Tuberculoid and lepromatous. What is lepra reaction? You know, very common question in exam. What is lepra reaction? After starting to you should tell that after starting treatment, usually there is an alteration in immune system. Immune system is hyperactivated for some time, for some period. After starting treatment, the immune system is hyperactivated. That's why there is increased symptoms. There is called lepra reactions. But remember, in lepra reaction in tuberculoid there is no new lesion. Very important, no new lesion, because but the existing lesions becomes more ugly looking. But there is no new lesion. This is a lepra reactions. Anyway, you know what is iris? এত আওয়াজটা কোথায় হচ্ছে রে? হ্যাঁ, ফ্যানের? এই ঘরটা এসি নেই না? যাই হোক, anyway, you know what is iris? IRIS? Anybody, any guess? Not I. It is not iris. It is a disease. IRIS. Iris is a just as a মজার ব্যাপার, তাই বলি আইরিসটা মনে রাখতে হবে, তোমাদের পরে মনে রাখতে হবে আরো ভালো, বাট রিমেম্বার ইট, আইরিস জানতে অসুবিধা নেই। ইটস এ ইমিউন রিকনস্টিটিউশন, syndrome, immune reconstitution, তারপর কি আছে আইরিস, immune reconstitution syndrome. এটা কি হয়, it is occurs in HIV patient, like lepra reaction. আমি এই কারণে মনে পড়লো যে like lepra reactions but more common because HIV lepra এখন leprosy কমে আসছে, but HIV patient এখন আছে অনেক। এই যেহেতু lepra, iris is the same as lepra reaction, occurs in HIV patient. When you start treatment, there is increased symptoms. How increased symptoms when you start treatment manifest? Suppose the patient has tuberculosis, you start ART or antiretroviral therapy. Patient has flare up tuberculosis. Tuberculosis flare up. The tuberculosis যা ছিল cough, fever সব বেড়ে গেল at the start of the treatment of the HIV. তাহলে it is called immune reconstitution. অথবা either there is flare up of the existing infections or there is new infections. Patienটের কোনো cryptococcal infection ছিল না, after starting ART antiretroviral therapy পেশেন্টের ইয়ে হয়ে গেল, ধর cryptococcal infection হয়ে গেল বা টক্সোপ্লাজমা হয়ে গেল। এই যে নতুন ইনফেকশন হলো বা একটা এক্সিস্টিং ইনফেকশন বেড়ে গেল, দ্যাট ইজ কল্ড আইরিস। বাট ইট ইজ নট লাইক দিস লেপ্রা রিয়াকশনস, it is not associated with increased CD4 count. But it is not associated with decreased CD4. CD4 count মানে জানো, তোমরা জানো CD4 count হচ্ছে একটা HIV পেশেন্টে দেখা হয় যে তার ইমিউন স্ট্যাটাস কত, যদি দেখা হয় CD4 কাউন্ট দিয়ে। তো CD4 কাউন্ট কিন্তু কমে না, CD4 কাউন্ট কমে না, বাট আইরিস হয়। আইরিস মজা পড়ছে, আইরিস হলে করবো কি তাহলে? টিবি বন্ধ করে, টিবির ওষুধ বন্ধ করে দেবো? নো, আমরা ART এবং ATT দুটোই চালাবো, ঠিক আছে। আরেকটা স্কুল বলে না, যদি তুমি ধরতে পারো যে টিবি আছে আর HIV আছে, টিবি আছে, এটা ভেরি ইম্পর্টেন্ট কোশ্চেন। এটা কিন্তু একটু ভালো বলতে পারলে জিজ্ঞাসা করতে পারে, ওরাল কোশ্চেন ফেস করতে পারো না। তুমি একটা পেশেন্টের HIV হয়েছে, টিবিও হয়েছে, তুমি কোন ডিজিজটা আগে ট্রিট করবে? HIV আছে, টিবিও আছে, হ্যাঁ। এবার কোশ্চেনটা এভাবে বলা যায়, স্যার ইট ইজ এ ভেরি স্পুটাম পজিটিভ টিবি, তাহলে আমি তাকে টিবিটা আগে ট্রিট করতে শুরু করবো, বাট উইদিন 1 month আই উইল হ্যাভ টু স্টার্ট ART irrespective of CD4 count. That is the complete answer. Very catch question in exam. যে একটা পেশেন্ট HIV হয়েছে, ভেরি কমন, HIV এর সাথে টিবি ভেরি কমন। একটা পেশেন্ট HIV হয়েছে, টিবি হয়েছে, তোমার কাছে পেশেন্ট এলো দুটোই আছে, টিবি আছে, পেশেন্ট ইজ এ HIV পেশেন্ট। হাউ উইল ম্যানেজ করবো? এরকম বলবো, স্যার আগে ওকে আমি CD4 কাউন্টটা দেখে নেবো, বেসিক CD4 কাউন্ট দেখে নেবো, তারপরে কি ATT স্টার্ট করবো। উইদিন 1 month irrespective of CD4 count I will have to start ART. কেন না? টু অ্যাভয়েড আইরিস। কি আইরিস হচ্ছে ATT স্টার্ট করার পরে এটা ফ্লেয়ার আপ হতে পারে টিবি, আমি সেটাকে অ্যাভয়েড করার জন্য আগে, বাট গাইডলাইন হচ্ছে নট অ্যাবাভ 1 month। তুমি 1 মাসের বেশি তুমি ATT দিয়েই যাবে, বলো আমি পরে করছি ART দিচ্ছি, করা যাবে না। ইউজুয়ালি most of the doctors started within 15 days, but you can wait up to 1 month guideline, but you'll have to start antiretroviral therapy. Anyway, এটা আউটসাইড আলোচনা, বাট দিস আর দ্য কোশ্চেন তুমি ওরালি ফেস করতে পারো। পারপিউরা, ভেরি ইম্পর্টেন্ট কোশ্চেন। পারপিউরা, what is purpura? Purpura, there are some definitions. What is called macule? Macule is a change in color without elevation, that is the rose spot or typhoid. কোনো পার্টিকুলার ফ্যানে আওয়াজ হচ্ছে নাকি? না, সবগুলো ফ্যানে আওয়াজ করছে না আওয়াজ। এনিওয়ে, তো ম্যাকিউল, এগুলো একটু জানতে হবে যে ম্যাকিউল কাকে বলে, প্যাপিউল কাকে বলে, ভেসিকল কাকে বলে, ডেফিনেশনস কি। ম্যাকিউল ইজ দ্য ডেফিনেশন, বাই ডেফিনেশন ইট ইজ আ এলিভেশন, কোনো এলিভেশন হয় না। প্যাপিউল হচ্ছে রেজড আপ এরিয়া, ভেসিকলস হচ্ছে ফ্লুইড ফিল্ড এরিয়া। পেটিচি ইজ আ হেমারেজিক স্পট। এই পেটিচিটা ভেরি ইম্পর্টেন্ট। থ্রম্বোসাইটোপেনিয়া, ডেঙ্গু কেস। এই তো লিসেন প্লিজ লিসেন, আস্তে, এত হামিং করো না, এত চাচানো যাচ্ছে না। শোনো, যদি পেশেন্টের ডেঙ্গু পেশেন্ট থাকে, ইউ উইল ফেস দিস কোশ্চেনস যে পেটিচি কাকে বলে। হোয়াই ইউ কল ইট পেটিচি? পেটিচি হচ্ছে কারণ we get it in dengue patients. Peticci is a hemorrhagic spots less than 1 millimeter, does not disappear on pressure. Peticci dengue patient হয়। Peticci is a sign of capillary fragility. Thrombocytopenia পরে, thrombocytopenia is not a sign of thrombocytopenia, it is a sign of capillary fragility. Thrombocytopenia added the features to it. So petechiae is the signs of capillary fragility. কি করে ডেঙ্গু টেস্ট টুর্নিকেট টেস্ট জানো? এই এভরিবডি লিসন, টুর্নিকেট টেস্ট না পারলে পরীক্ষা ফেল করে দেবে। টুর্নিকেট জানো ডেঙ্গু পেশেন্টের টুর্নিকেট টেস্ট কিভাবে করে? ইফ ইউ ক্যানট আনসার পাস করাবে না ডেঙ্গু পেশেন্টের। টুর্নিকেট টেস্ট কিভাবে করে? একটা আর্মের জাস্ট আমি বলেছি কোনো কনফিউশন রাখবে না। বলে স্যার আমরা একটা আর্মে একটা বিপি কাপ বাঁধবো, বেবিটা দেখি সিস্টোলিক বিপি মাপবো, ডায়াস্টোলিক বিপি দেখবো। কোনো কোশ্চেন থাকলে এখনই জিজ্ঞাসা করবে, এই কোশ্চেন জিজ্ঞাসা ডেঙ্গু পেশেন্ট থাকলে জিজ্ঞাসা করবে। সিস্টোলিক বিপি আর ডায়াস্টোলিক বিপির মাঝখানে কাপটাকে রাখবো, কতক্ষণ রাখবো? 5 মিনিট রাখবো, 5 মিনিট। তার আগে হাতে আর্মের উপরে একটা 1 স্কোয়ার সেন্টিমিটার একটা এরিয়া এঁকে নেবো, স্কোয়ার 1 স্কোয়ার সেন্টিমিটার একটা এরিয়া ফোর আর্মে এঁকে নেবো, নিয়ে তারপরে এই কাজটা করবো, করে 5 মিনিট রাখবো। তারপর সেই 1 স্কোয়ার সেন্টিমিটার এলাকাতে কতগুলো পেটিচি হয়েছে দেখবো। If it is more than 20, then the test is positive. তাহলে পজিটিভ টেস্ট মানে যেটা টুর্নিকেট টেস্ট পজিটিভ, মানে there is a significant capillary fragility. Capillary fragility is the pathogenesis for dengue. You know, dengue is thrombocytopenia থেকে ইম্পর্টেন্ট হচ্ছে ক্যাপিলারি ফ্রেজিলিটি। ডেঙ্গুতে দুটো সিমটম হয়, তাই তো? একটা থ্রম্বোসাইটোপেনিয়া আর হচ্ছে ডেঙ্গু শক সিনড্রোম। ডেঙ্গু শক, এই তার চুমাচুক কর, বেশি কথা বলে। ডেঙ্গু শক সিনড্রোম, ডোন্ট ফরগেট, ডেঙ্গু শক সিনড্রোম ইজ ডিউ টু ক্যাপিলারি লিকিং। Increased capillary fragility, there is capillary leaking and dengue shock syndrome. এর সাথে থ্রম্বোসাইটোপেনিয়ার কোনো সম্পর্ক নেই। থ্রম্বোসাইটোপেনিয়া, ডেঙ্গু থ্রম্বোসাইটোপেনিয়া, হ্যামারেজিক ফিভার, ডেঙ্গু হ্যামারেজিক ফিভার ইজ এ সেপারেট এন্টিটি, সেপারেট ডিজিজ। তাহলে ডেঙ্গু হ্যামারেজিক ফিভার আর ডেঙ্গু শক সিনড্রোম দুটো আলাদা জিনিস, দুটো প্যাথোজেনেসিস আলাদা, দুটো আলাদা ডিজিজ। একসাথে হতে পারে মানুষের, কিন্তু ডেঙ্গু হ্যামারেজিক ফিভার তার প্যাথোজেনেসিস ক্যাপিলারি ফ্রেজিলিটি, ডেঙ্গু শক সিনড্রোম, আর ডেঙ্গু হ্যামারেজিক ফিভারের তার ফ্যাসিলিটি তার হচ্ছে থ্রম্বোসাইটোপেনিয়া। দুটো একসাথে হলে তখন যে পেটিচি হচ্ছে, ক্যাপিলারি ফ্রেজিলিটি আছে, থ্রম্বোসাইটোপেনিয়া অ্যাগ্রাভেট করছে। বাট বেসিক প্যাথোজেনেসিস, বেসিক প্যাথোলজি ইজ ক্যাপিলারি ফ্রেজিলিটি। বেসিক কোশ্চেন। এনিওয়ে, তাহলে ইকোইমোসিস হলো কজ দ্য পারপুরা, থ্রম্বোসাইটোপেনিয়া, প্রাইমারি ইমিউন থ্রম্বোসাইটোপেনিক পারপুরা। তোমরা জানো ইট ইজ অটোইমিউন ডিজিজ, ইমিউন থ্রম্বোসাইটোপেনিক পারপুরা। আগে বলতো যে তোর ইমিউন থ্রম্বোসাইটোপেনিক পারপুরা, আর আগে বলতো ইডিওপ্যাথিক পারপুরা, এখন ইডিওপ্যাথিক বলে না, এখন বলে ইমিউন থ্রম্বোসাইটোপেনিক পারপুরা। সেকেন্ডারি কজেস হচ্ছে ডেঙ্গু, ম্যালেরিয়া, ইনফেক্টিভ এন্ডোকার্ডাইটিস, অ্যাপ্লাস্টিক অ্যানিমিয়া, লিউকেমিয়াস, লিম্ফোমাস, all cause thrombocytopenia. Hypersplenism, the features of hypersplenism. For the features of hypersplenism means pancytopenia. Hypersplenism কি হয়? Pancytopenia. All the series of the blood, RBC, WBC, platelet সব কমে যাবে। আরেকটা কন্ডিশনে এটা হয়, সেটা হচ্ছে অ্যাপ্লাস্টিক অ্যানিমিয়া। অ্যাপ্লাস্টিক অ্যানিমিয়া স্প্লেনোমেগালি কখনো হয় না, আর হাইপারস্প্লেনিজম অলওয়েজ দেয়ার ইজ স্প্লেনোমেগালি। তাহলে হাইপারস্প্লেনিজম হচ্ছে সেম, ডিস্ট্রাক্টিং all the components of the blood, causing pancytopenia, and aplastic anemia also causes there is defect in production, also causes all the defects in all the three series of the blood, but aplastic anemia never causes splenomegaly. Anyway, তারপরে the leukemia এগুলো হবে disseminated intravascular coagulation, disseminated intravascular coagulation। এখানে কি হয় না, সমস্ত পেরিফেরি ক্যাপিলারি গুলো ক্লটিং হয়ে যায়। সেই ক্লটিং হওয়ার সময় তারা সমস্ত প্লেটলেট আর ক্লটিং ফ্যাক্টর গুলো ওখানে এনট্যাঙ্গেলড করে নেয়, যার ফলে পেরিফেরিতে কোনো ক্লটিং ফ্যাক্টর আর আরবিসি আর প্লেটলেট পাচ্ছি না, বিকজ দের ইজ ডিসেমিনেটেড টার্মটা লক্ষ্য কর, ডিসেমিনেটেড ইন্ট্রাভাস্কুলার কোয়াগুলেশনস। প্রত্যেকটা ক্যাপিলারিতে ক্লট হয়ে গেছে, দ্যাট ক্লট হ্যাজ that exhausted the coagulation factors and the platelet also. That's why there is a dearth of platelets and coagulation factor in the blood. That's why there is excessive bleeding. তো দুটো কাজই হচ্ছে এখানে, একটা এক্সেসিভ থ্রম্বোসিস হচ্ছে, আবার এক্সেসিভ ব্লিডিংও হচ্ছে। তো ডিআইসি ইজ এ ডুয়াল, এক জায়গায় থ্রম্বোসিস হচ্ছে ওর জন্য আরেক জায়গায় ব্লিডিং হচ্ছে, সেটা ডিআইসি pathogenesis. Anyway, TTP, thrombotic thrombocytopenic purpura, some drugs, bone marrow suppression, you know, many drugs can cause bone marrow suppression. They are all causes aplastic anemia. Last slide, আর বকবো না, দাঁড়া। edema আছে, edemaটা there is what is edema? There is excessive amount of tissue fluid, causes congestive cardiac failure, increased central venous pressure, causes the congestive cardiac. Why there is edema? There is increased central venous pressure. Renal cause, there is hypoproteinemia. that cause anemia. Nephrotic syndrome and reduced due to nephrotic syndrome. Why hypoalbuminemia causes edema? Reduced oncotic pressure. Answer গুলো ছোটপট দিয়ে দেবে, reduced oncotic pressure. ফাম্বল করবে না। Hypoproteinemia, malnutrition, these are the causes of hypoproteinemia, malnutrition, cirrhosis of liver, and there is cirrhotic liver disease, cirrhosis liver, দুবার লেখা হয়েছে। এনিওয়ে এটা ক্রনিক লিভার ডিজিজ লেখা উচিত ছিল, ক্রনিক লিভার ডিজিজ আর সিরোসিস অফ লিভার, সবগুলোর কারণ হচ্ছে দিস কজেস হাইপোঅ্যালবুমিনেমিয়া। তো লিভার ডিজিজে যদি বলে ইডিমা কেন হয়েছে, ইট ইজ ডিউ টু লো অ্যালবুমিন। হ্যাঁ, অ্যাসাইটিস কেন হয়েছে? বিকজ অফ লো অ্যালবুমিন অ্যান্ড পোর্টাল হাইপারটেনশন, দুটোই অ্যাসাইটিসের কারণ। আর ইডিমা কেন হয়েছে? অনলি এখানে পোর্টাল হাইপারটেনশন কি ব্যাপার না, এখানে অনলি হাইপোঅ্যালবুমিনেমিয়া। আচ্ছা, আদার সাইড মধ্যে অ্যাঞ্জিওনেফ্রিক এডিমা, আই নো দ্যাট ইজ ভেরি ডায়াবেট। আমরা একটু আগে বিয়ন্ড ডেফিসিয়েন্সি বলছিলাম, ডায়াবেরি এটা ওয়েট বেরি যেটা হয়, ওয়েট বেরিতে কজেস এডিমা। Localized edema may be localized edema, filaria, lymphatic and venous obstruction. Edema may be non-pitting edema. It's called mixed edema. Mixed edema can also cause swelling of the feet, but that edema is called non-pitting edema. Non-pitting. Pit করলে বসে না একটা। আরটা ভেরি ইম্পর্টেন্ট, এটা ক্যাচ কোশ্চেন ইন এক্সাম, প্রিটিবিয়াল মিক্সড এডিমা, মানে হচ্ছে টিবিয়ার ওপরে একটা ইডিমাটাস টিস্যু রিয়াকশন হয়। That is not due to hypothyroidism, it is due to thyrotoxicosis. Don't forget it. The pretibial mixed edema, though it is the term is mixed edema, is the features of thyrotoxicosis, not hypothyroidism. Though it is called pretibial mixed edema, it's the features of hyperthyroidism. The features of hyperthyroidism. Okay. So we finish here today. Next class, we'll progress on abdomen examination. The two classes we have spent for general survey and